for the session. So we are at the final lecture today. Quite a lot of ground to cover, which is why we wanted 2 hours of your time. So I will go first, finish the talks on cross-sectional study designs, ecologic studies, and diagnostic studies, and then hand over to Taryn to wrap up with the talk on meta-analysis. And at the very end, Mia wanted to say a few words on behalf of the organizers, and then we will close, okay? So that's the plan for this last session. So let me share my screen and tell me if you're able to see the slides. Are you able to see my slides?
Yes, we can see them.
Okay. Is that okay? Slides are visible?
Yes.
All right. So cross-sectional studies. This is a type of an observational study. There's nothing randomized or experimental about cross-sectional study. They're one of the simplest studies one can do in epidemiology. And the goals are often quite simple. All we're trying to estimate in a cross-sectional study typically is the prevalence of some disease, prevalence of knowledge, prevalence of attitudes and practices, and so on and so forth. So the Santa Clara County study that we looked at in the past is a textbook example of a prevalence cross-sectional study. On 2 days, 3rd and 4th of April of this year, they tested Santa Clara County residents for antibodies to SARS-CoV virus, and then they estimated the prevalence to be 1.5%. Okay, 1.5% of those tested had antibodies. That is it. That's the goal of the study, right? Classic textbook example of a prevalence cross-sectional study. So what makes it cross-sectional? Cross-sectional, the word implies that it's a slice. It's a slice in time in a population, which gives you like a static picture of what is happening to a very dynamic population, right? So think of a cohort study as a video segment that goes forward in time, and think of a cross-sectional study as a one-time Polaroid picture, right? It's a snapshot versus a more dynamic continuing evolution of the population, right? So a cross-sectional study is not a video, it is a one-shot snap of what's happening in a population. So even though people are coming in and out of a population, people develop the disease, they get better, they develop the disease again, all sorts of underlying trajectories are in some way simplified because we are only sampling at one point in time, right? Now, who knows, if you repeated the Santa Clara County study today, the prevalence of antibody positives may be 10% instead of 1.5%, right? Because the epidemic has evolved over time, right? So sampling at one time is what makes it a cross-sectional study. So at one point in time, we generally collect all the information about exposure and information about outcomes at the same time. For example, we could say, in addition to collecting information on COVID antibodies, we could also collect information on exposures such as the age of the people, the gender, whether they're smokers or not, whether they have COVID symptoms or not. So exposures and outcomes are both collected simultaneously, which is also an issue because temporality is never clear from cross-sectional studies. You can't quite tell which came first, right? The exposure came first or outcome came first is not easy to make a cross-sectional study. And can everyone please mute their microphones, please? Thank you. All right. So because of the single point cross-sectional sampling, we can never really tell when exactly somebody developed the disease. We don't know if they'll get the disease after the survey because we're not following them up. And we really cannot tell the temporal sequencing. That's a huge limitation. That's why prevalence is typically what we get We rarely ever get incidence from a cross-sectional study, right? So short duration illnesses generally get missed in a cross-sectional survey, because by the time we sample them, it's very hard to know who had the episode before and who will get the episode after. Which is why for diseases like short duration diseases like common cold or diarrhea, pneumonia, we generally don't use prevalence as the outcome, right? We would like incidence, number of episodes of diarrhea per child per year, or number of episodes of acute respiratory tract infection per person per year is what we would like. And those episode information you cannot quite capture in a prevalence survey. Prevalence is excellent for long duration or chronic condition, right? So if we say hypertension, we always think about prevalence. Diabetes, we think about prevalence. Dementia, we think about prevalence. Depression, we think about prevalence. Not quite acute short duration illnesses. They tend to be underrepresented in a cross-sectional study. People who die by the time we even get to sample them are again obviously missed in a prevalence study, right? A prevalence study is invariably likely to pick up survivors in any population, right? Imagine doing a study, a prevalence study on Ebola, while by the time you go house to house, you find people there. Obviously, you find people who have survived Ebola. You don't count the people who died of Ebola because they're not at home to be included in your sample survey. So sample surveys will always miss people who already died and therefore will not quite capture the true disease burden in a given population. So that's basically what a cross-sectional study is. It's also called as a prevalence study. Sometimes we just use the term survey. Sample survey, cross-sectional study, prevalence study are all synonyms, okay? They all mean the same thing. They give you a snapshot of the picture of health at a given point in time. We sample both exposure and outcome at the same time. They are fine if all we want is to measure disease burden. But can you get at a causal link between something and something? The answer is absolutely not, right? We will never be able to make any major causal conclusions that smoking is causally associated with COVID. None of that is possible from a cross-sectional study. Causality requires follow-up, right? Causality requires either a cohort study or a randomized trial, depending on the nature of the exposure. Now, the most important outcome we get from a cross-section study is a point prevalence. At one point in time, what is the prevalence of a given disorder in a community, right? So the equation is point prevalence equals to C over N. C is the number of observed cases at time T. N is the population size at time T, right? That's basically what point prevalence is. So the Santa Clara County, they said, we tested 3,330 adults and children for antibodies on those 2 dates. 50 people were positive for one of the 2 antibodies. That gives you a point prevalence of 50 over 3,330, which works out to 1.5%. Okay. So what is the relationship between prevalence and incidence, right? Think of incidence as the feeder into a population. Incidence is new people with disease occurring in a population. Prevalence is the total pool of disease in a population. So prevalence is pre-existing disease plus new disease added makes up the total prevalence pool. Now, how can you exit from a prevalence pool? Can you please all mute your microphones, please? Can you please mute your microphones, please? Can you please mute your microphones? Can you please mute your microphones? that okay? All right. Restarting the slide. So you can exit the prevalence pool through a couple of ways. One is somebody dies, they're no longer part of the prevalence pool, or they recover from the disease and they are removed from the prevalence pool. So in general, the equation is, could you please mute your microphones, please? All right, I'm going to resume the lecture. All right, so incidence adds to the prevalence pool, while fatality and recovery removes people from the incidence pool. So the crude equation is prevalence is incidence times duration of the disease. Any condition where the incidence is high, the prevalence will also be high. Any situation where the duration is long, such as diabetes, heart disease, mental health, where the duration is long, the prevalence will automatically be higher. So that's basically what this graphic is trying to tell you. Prevalence will always be high in a population if the disease becomes long duration. There's prolongation of life, even if there's no cure. There's increased incidence. There's in-migration of people who are sick. There's out-migration of healthy people. And anytime you have better diagnosis and reporting, the prevalence can go up as well. So sometimes we start a new project in a community where there was very little, say, testing happening. And suddenly you test for something, it looks as if the prevalence has gone up. But in matter of fact, it may just be because we are now detecting people while earlier they were missed. So you should always worry whether the observed increase in cases is because you're testing more aggressively or whether it's a genuine increase over time. And the opposite of exactly what I said applies to what situations will decrease the prevalence of a disease. For example, if a disease is highly fatal, as in the case of, say, Ebola, you will find the community prevalence to be lower because people are already dead and not included in the sample survey. Short duration diseases will lower the prevalence as well, because once people enter the prevalence pool, they quickly exit because they have recovered from the disease. So prevalence surveys are excellent. If all you want is a quick, rapid, relatively inexpensive look at the health status of a population, you can look at several exposures and several outcomes at the same time. For example, you could do a prevalence survey of several non-communicable diseases at the same time. Diabetes, heart disease, obesity, so on and so forth. And they are particularly good for common diseases with long duration and can often help us fine-tune hypotheses for future studies we are looking at. The disadvantages being that since we are only doing a cross-sectional look, we really cannot get incidence. We can only get prevalence. We can only get people who survived. Inherently, survivors are oversampled. And we really cannot establish temporality or directionality. So we don't know whether exposure caused the disease, or we don't know whether disease changed the exposure level in a population. We can never quite tell in a prevalence survey. Now, could you have bias in cross-sectional surveys? The answer is yes. We've already seen some of that in the prevalence surveys that we've looked at. For example, non-response bias is a big problem in all prevalence surveys, right? Who says yes? Who says no when you go house to house, for example? Volunteer bias, If the worried well want to get into your study at a higher rate than others, then you can have a volunteer bias, people who are eager to participate. Selection of survivors, we've already spoken about, and any sampling method that is non-random will increase your risk of selection bias. So for example, selecting people through Facebook would be an example of a non-random sampling scheme, because there's nothing random about it. You have to be on social media. That already reduces your pool of people. And you need to be eager and willing to agree to be in the study. So that changes your profile. And we already learned that in the Santa Clara County study as well. So here is a nice graphic showing how your sampling frame itself. So I would say if your sampling frame itself is biased, let's say, for example, if you were to use a voter list, okay, to a list of voters to do your sampling. But let's say if the poorest people are simply not even in your voters list because they don't have a stable home, or they were not at home when the voter list was created, or the voter list only is limited to the main area and leaves out the hamlets outside of the main village, then you already have a biased sampling frame. So therefore, you will only have a biased sample afterwards because your sampling frame itself is problematic. So you could have non-random sampling bias, non-coverage bias. All of this can be exaggerated. So when we do survey sampling, in fact, there are textbooks on how to do survey samplings. There are entire courses. I've taken an entire course on how to do survey sampling, and there's specialized statistical software that we'll have to use to analyze survey sample results, because sometimes we first sample states. Within states, we sample districts. Within districts, we have to do a sample of households. Within households, not everybody may be selected. So at every single stage, there is a certain selection probability of getting into the study. So we cannot just take the numerator and the denominator and compute the prevalence. We'll have to adjust for the fact that there is clustering. Clustering means within households, people are clustered on socioeconomic status, education, diet, and so on and so forth. So we have to adjust for clustering at each level. And that's why survey samplings are complicated and need to be done quite well. And analysis needs to be accounting for the survey design as well. And information bias is another big problem in all surveys. Quality of the instrument or the tool we use is quite critical. So if we did an antibody-based COVID prevalence survey, the antibody test itself could be falsely positive or falsely negative. And you will hear more about that in the upcoming talk on diagnostic studies. Questions? Go ahead.
For now, Madhu, there is no question.
Anyone else on the call who wants to ask a question can unmute themselves. Anyone? All right.
Prof.
Yes, please.
Elizabeth here.
Yeah. Go ahead, Elizabeth.
The question I have with regards to bias maybe is related to me as a journalist. How do I then determine the bias in the studies that I go through in journals, and determine what stands and what is heavily biased?
So as a journalist, Elizabeth, the first thing you'll have to probably find out is what kind of a study design. What is that journal article about? Is it a randomized trial? Is it a cross-sectional survey? Is it an ecologic study? You can already have a good sense of the value of a paper by just looking at the study design itself, right? So for example, if you're writing about hydroxychloroquine or a drug treatment, and then all you have is an observational study, that itself you will have to write about that and say, this is not a randomized trial. Therefore, there are likely to be serious biases in deciding whether the drug works or not. And here is all we can tell based on this study, right? Or if it's an ecologic study, which I'll cover next, that's very weak level of evidence, right? You cannot use an ecological study to decide whether something is a good drug or a treatment or whatever. So that itself is very helpful. Just critiquing the design itself, because once you know what design it is, you already know that design has certain positives and certain negatives. Secondly, if you do not have the epidemiological ability, I mean, this course is very short, to critique and identify bias in each study, then you will have to reach out to epidemiologists like me or Ngozi or Iya or Chido or whoever is in your neighborhood, in your country, and have them critique it for you, and then you report based on what they tell you. Does that make sense?
Yes, it does. Then it leads to my follow-up question with regards to the journals that we as journalists could refer to, that you as the experts consider, and I quote, the Bible of science journals, if I may say that. Are there reliable journals that we could easily look at as journalists that cut through this bias?
Really, really good question. And I'm tempted to say that international medical journals that we consider or we call high impact journals generally should do a better job of picking out seriously flawed studies and rejecting them, right? So if Lancet publishes something, then you know it has been through 4 or 5 peer reviewers. You know that it has been looked at by multiple editors. You know it has been looked at by statisticians. Same for the New England Journal of Medicine or JAMA or British Medical Journal, or one of those international well-known high-impact journals. But we saw already that these journals have had big retractions in this COVID pandemic. They have rushed things. They have been sloppy in their peer review. While I would still generally maintain that I myself as an epidemiologist am more confident when I'm reading a peer-reviewed publication in a big peer-reviewed respected journal. So that itself, I think, is helpful. I won't give up on these journals just because they had some bad decisions in the current pandemic, or even in the past. Lancet, for example, published a terrible study in the past on an MMR vaccine and autism that created havoc in the medical community for decades. So they've done bad things, and I think every journal slips up one time or the other. So in general, you look for a peer-reviewed paper, which means not a preprint, not a press release, not somebody's tweet. None of them are acceptable publications, not somebody's report posted on the website. It needs to be vetted and peer-reviewed by experts. And then look for international well-known journals. I think that gives you more confidence as well. Beyond that, there is nothing you can do except to really critique it. You cannot just go by where it is published as a yardstick. Okay?
Okay, thank you.
All right. I will now move on to my next talk, right? Now we're talking about ecologic studies. So ecologic studies, let me explain what they are, and then I'll give you examples. Now, most studies that we have covered so far, randomized trials, case control studies, cross-sectional studies, cohort studies, they are done on individual human beings, right? On individual people. Occasionally, we do studies where we don't study people, but we study countries or districts or schools or states. We're doing big picture macro level comparisons between 180 countries to see whether this is correlated with that. So when the unit of analysis are populations or groups or aggregate of people rather than individuals, then we call them ecologic studies. I think a better term would be aggregate level studies. Aggregate means you're not taking individuals, but aggregates or groups of people, right? So here is an example. These are 13 states within the United States, and all they're trying to do is to ask a question so each dot is not a person, each dot is a state, data from one state in the United States, right? So let's take this dot, okay? I don't know which state it is, but for that state, the incidence rate of AIDS per 100,000 people, person years is given here. The incidence rate of tuberculosis is that, right? So that's for state 1, state 2, state 3, state 4, state 5, so on and so forth, right? So if you just had 2 pieces of information on each state, you're ready to make this particular plot. And then what does this plot tell you? This is also called a scatter plot, right? It tells you in general that the dots are all lining up around the diagonal, right? The diagonal is this line. Basically, it says anytime the incidence rate of AIDS is high, the incidence rate of TB is also high. And we know this is true. We know this is biologically meaningful, that people with HIV/AIDS often have TB and people with TB often have HIV/AIDS. So this is an ecological correlation. So you could do a correlation coefficient, or R, as we call it in statistics. And the R will be very high in this case, close to 1. 1 would mean perfect correlation. All the dots will be on the diagonal. And R of 0.8, which would probably be in this case, or 0.9, would mean a very good level of correlation. So here is an ecological correlation study with state as the unit of analysis on the correlation between AIDS and TB, okay? Here is an ecological correlation study on whether air pollution and fatality of SARS, not this current SARS, but the previous SARS outbreak in China, okay? So you see here, whenever the air quality index is very poor in various provinces of China, Beijing or cities, Beijing, Tianjin, Shanxi, Guangdong, and so on and so forth. And as the air pollution levels are high, the case fatality of people admitted with SARS in hospital was also high. And this was indeed confirmed to be true, that if you have a respiratory infection and on top of that you're breathing heavily polluted air, it can really increase case fatality. Okay, so here is a nice correlation study, ecologic study. Now these are easy to do. All you need is group level measurements. What's the air quality for Beijing and what's the case fatality for that disease in a given population, and you can put this together very quickly. Okay. Along the same lines, some months ago, there was an ecological study, the first one, showing a correlation between BCG vaccination and COVID-19, right? They took each dot as a country. So in fact, they took the BCG policy, whether a country gives BCG at birth to everybody or whether a country does not. They took that data from the World BCG Atlas that my team maintains and has put together. And then they looked at the death rate due to COVID from WHO or other publicly available sources. And they said, look, there's a nice correlation, right? Countries that give BCG generally have a lower COVID death rate, and countries that do not give BCG have a high rate of COVID deaths. And inspired by some of all these ecological studies, many countries are making all sorts of crazy policies. This is a scary policy from an Indian state saying that BCG will be given to adults between the age of 60 to 90 to reduce mortality among senior people. This is not based on any randomized trial, and it's based on this kind of weak ecological correlation study, which really makes me very, very nervous when policies are made on the basis of such poor ecologic studies. So I have been writing a lot along with my team on trying to debunk some of these decision-making on the basis of weak ecologic studies. So I wrote a piece in Forbes arguing that the evidence that BCG protects against coronavirus is very, very, very weak, right? We need randomized trials before we can say that. And I also wrote a skeptic's guide to ecological studies, because in this pandemic, people have lost their heads. All sorts of rubbish is being published as correlation, and it is driving everybody mad. There is so much noise in the literature, and I'll show you examples of the ridiculous type of studies being put out in this particular pandemic. And journalists, for most part, have been completely uncritical. They are willing to swallow anything given to them. They don't know whether it's an ecological correlation study. They just take it as gospel truth and write about it, and that adds to policymakers who are already confused. So what is wrong with this BCG ecological study, and why did we critique it? Firstly, you will learn later on in a second that ecological studies, what is true at the population level, does not have to be true at the person level or the individual level. Okay, we call that ecological fallacy, and I will explain that better in a second. We also critiqued that the testing rate in many poor countries, so many poorer countries do give BCG at birth, like India, for example, but India also has one of the lowest COVID testing rates in the world. So just because you didn't see COVID in these BCG countries doesn't mean there is no COVID. They simply may not be looking for COVID or testing for COVID. And the epidemic is on a completely different time scale across countries. So when this was published, I believe this was in March or April. I mean, so India may have been here, but India today is here. Brazil is gone there. So is Indonesia, so is Pakistan, so is Philippines, so is Peru, so is Argentina. The epidemic is exploding in many countries which have been giving BCG now for many years. So what was true 3 months ago in this pandemic is simply not true today. So you just cannot make ecological correlation such a rapidly changing, evolving. I mean, India and Brazil are just exploding with COVID, and both are giving BCG. South Africa gives BCG, and the epidemic is just escalating in South Africa. So that's why I was very unhappy with this kind of analysis. And then there is this huge problem of confounding. All of you already know what confounding is, and you will understand that. So India gives BCG, Nigeria gives BCG, South Africa gives BCG, Bangladesh gives BCG. The age structure of these populations are very young, right? The percentage of elderly people in these countries is much, much smaller than, say, UK or Spain or France or any of the European countries, or even US or Canada. US, Canada, European countries have large numbers of elderly people, right? So it's simply not a fair comparison to compare various countries and completely ignore confounding by age. So whatever difference you're seeing could be an age issue and nothing to do with BCG. Same thing. Countries that give BCG also gave MMR for measles, mumps, and rubella. Countries that give BCG also give polio vaccine. Countries that give BCG could also be doing something else. So how do you know it's BCG and not a MMR vaccine that's protecting us from COVID, right? We don't know. That's confounding, right? It's all mixed up and we cannot quite tell, right? Countries that give BCG may also have high rates of malaria. How do we know that there is no protection because of malaria in the population? We don't know, right? And there are lots of inconsistencies. Like I said, India, Brazil, Peru, Russia, Iran, Pakistan, Mexico, even China gives BCG. And China is where the epidemic started. So lots of inconsistencies in this BCG theory. And there's some biological issues as well. I mean, BCG, why should BCG given 60 years ago when you were a baby protect you against COVID today, right? Makes no biological sense. Even for TB, it doesn't protect adults beyond a certain age. So this pandemic has resulted in some pathetic stuff by researchers like me, putting out all sorts of rubbish in the name of ecological correlation. Anybody who has an Excel spreadsheet can now put out an ecological study, right? That's all it takes. You take the data from here and there and you throw it in a spreadsheet and you do a regression line and you're done and you're ready to publish. So here is an ecological correlation on vitamin D, right? Countries with more vitamin D levels in the population have lower levels of COVID. So the whole bunch of people now chasing this vitamin D story. This is smoking. This scared the heck out of me. That somehow the more smoking rates the lower the number of COVID cases, because smoking is dangerous from every single study anybody has ever done for a whole bunch of diseases. So if you're going to suddenly say that smoking protects against COVID, that's a huge statement to make. And I would never make that from an ecological study, right? This could well be confounding by something else that's not looked at. And the last straw was this garbage study published a week ago on cabbage and cucumber consumption, right? Imagine cabbage, number of cabbage eaten or cucumber consumed, and deaths due to COVID, right? And they're saying, oh, countries that eat a lot of cabbage and cucumber have, lower rates of COVID mortality. I mean, complete garbage, rubbish stuff. It's being put out in the name of research and preprint, confusing the hell out of people. This is just terrible, terrible research. It's fine to do these kind of comparisons and say, okay, there may be something here that's worth studying further. That's about all you can really say from an ecological study, but we really cannot make any serious policy or clinical decision on the basis of this. So it's low cost, easy to do, convenient. And sometimes all you have is aggregate level information. So it makes sense. It's very simplistic. Everybody understands a regression line, right? It's very appealing to the people. It's appealing to journalists. It's beautiful to put on a WhatsApp and say, hey, look, cucumber and cabbage will protect you, right? And they're perfectly fine for generating new hypotheses that requires further research. But they have massive limitations, ecological studies, right? The confounding is a massive problem. You often have collinearity. Collinearity means exactly what I said. Countries that give BCG will always be the same countries that also give MMR, will be the same countries that also give polio vaccine. So how do you know it's BCG, right? These variables are collinear, right? They vary together linearly. Temporal ambiguity, you cannot tell which came first in an ecologic study. And then there's ecological fallacy, which arises from thinking that the correlation you observed at the group level, country level, is also necessarily true at the individual level. Okay, that's called ecological fallacy. And I'm going to try and show it to you in a graphic way in a second. But here is an example on smoking and anxiety disorder, and there's a correlation. Okay, so you see a correlation in these countries that higher the proportion of population smoking, greater the prevalence of anxiety disorders, okay? But you can never tell from this graphic whether people started smoking, then ended up with anxiety disorders, or it's because they're anxious, they started smoking, right? You cannot have any resolution on the sequencing of events. Which came first? Remember, for a cause to be a cause, it must precede the effect, right? Cause must come first and then the effect. It's impossible to tell from this picture whether an anxiety disorder made people smoke more, or it's smoking that somehow provoked an anxiety disorder. We can never tell. So here is a beautiful illustration of what we call aggregation bias. Bias that suddenly appears in the data set because we are now lumping people in groups, okay, in aggregates. So here is an illustration. So here is an exposure, okay? Let's say this exposure is smoking, okay? And this is COVID, right? So as smoking levels increase, right, on this axis, let's say the COVID levels seem to be going down. This is country A, this is country B, this is country C, this is country D. So you see one consistent trajectory across 4 countries, that exposure and the outcome are negatively correlated. Okay, whatever the exposure is, whatever the outcome is. So if you had studied these 4 countries separately, then you would have gone home saying across 4 countries, we are seeing that an increase in the exposure reduces the risk of the outcome, right? So far, so good. But then, and that's the directionality, right? The correlation is negative at the individual level. But then if you now take these 4 countries and you reduce them into a dot each, right? You collapse the 4 countries into 4 dots. Now you see a directionality that goes in the opposite direction, right? As exposure goes up, the risk of the disease seems to go up because you're now comparing across these 4 countries. So by lumping all of them, you lost the directionality that you saw within a country at the individual level. This is called aggregation bias, and that's the challenge that we have. What you see at the country level may or may not hold true at the individual level within a given country. And confounding is always a massive problem. We cannot quite adjust for all confounders in ecological studies because we often don't have the data to adjust for confounding. And the individual level is where we can really do a good confounding adjustment. So that's just a quick summary of ecological studies. They are big picture, aggregate correlation studies. Unit of analysis is not people, but countries or districts or schools or hospitals. They're great for generating hypotheses, but they have huge flaws. They cannot adjust well for confounding. They're very prone to this problem called ecological fallacy. And there's also missing data. You cannot have all the confounders in the data set for you to adjust for. So in this pandemic, people have been egregious with some disastrous research, all sorts of rubbish correlations being thrown around. Most of them are completely meaningless, and we need much stronger individual data to figure out whether those factors are valid or not. And journalists need to be super critical. The minute you understand it's an ecological correlation, that's the first thing you report in your studies, in your journalism. You say this is a ecologic studies with huge potential for bias, and all it is an early signal that this is worth studying. It simply is inadequate for any kind of policy or clinical decision making. Nobody should be giving BCG on the basis of an ecological study. I don't care what the results are. I want to see a randomized trial before we give BCG to prevent COVID, right? That's the level of evidence we need to actually act on these sorts of things. So they're okay as an early hypothesis generating exercise, but not good enough to confirm anything, certainly not causality. Questions? Questions, anyone?
Yeah, there is one question. So the question reads, uncertainty in science is a big challenge for us journalists when reporting. What's your advice when handling issues of uncertainty in science?
So uncertainty is something you have to communicate, right? There are many things you could say to communicate the uncertainty. First, you could say, overall, how good is this study design, right? Is it a study design that can really nail it? For example, a well-done large randomized trial really lowers uncertainty, okay? At least those of us who are epidemiologists will absolutely take that as a much, much better evidence and go with it rather than a bunch of weak observation studies. So experimental is much less uncertainty than observational. A well-designed cohort study gives you much more certainty than a cross-sectional study or an ecological study. Peer-reviewed, vetted study published in a good journal gives you less uncertainty compared to something that is a press release, somebody's PowerPoint slide, somebody's tweet, some preprint posted somewhere. That's the kind of things you can make. And within a given study, you can also communicate uncertainty by saying, based on this, the prevalence could be as low as 5% or as high as 15%, because that is the confidence interval that we are finding in this study, right? You can provide a range rather than a single number that also tries to capture uncertainty in a better way. And then you can also capture uncertainty by saying, this is the 5th randomized trial on hydroxychloroquine. All 5 have consistently showed that hydroxychloroquine does not work. Now you're starting to approach certainty, right? And that's exactly true for hydroxychloroquine, right? Every single trial has been negative. That's why I don't believe hydroxychloroquine works. And I don't care what Trump tweets or what that woman said on WhatsApp, right? So that's not what we should be looking at. We should be looking at hard evidence, and that's how you communicate certainty or uncertainty to your readers, I think. Ngozi, you want to add anything to this really good question?
No, I think you did well, Madhu. I'm actually looking at the chat, and there's other questions coming up as well. So I was going to let Ia ask you that.
Okay. Any other questions?
Yeah, the other question is, when can we trust prevalence or ecological studies as journalists and should report on them? Again,
prevalence study can be, if it is done well, and if the entire objective is to get a prevalence of something, then if it's done well and the selection is reasonable, it's unbiased, then you can trust that, right? It's just that you would not use a prevalence study to talk about any causality, right? You would only talk about a prevalence study, and its job is to estimate prevalence of some condition. So which study allows you to say what is the real issue here, right? So I would never, ever make any causal inferences on the basis of a prevalence study or an ecological study. I would treat them as early stage, weak observational data. But if the whole objective is to get a prevalence of something, and if it's done well, then I'm fine with it. Then I would report it exactly that this is what the prevalence was. Here is the confidence interval or the uncertainty around this prevalence. Here is the potential selection bias issues, right? That's the kind of discussion that I would have, but I would not make this causes that type of a statement in using a prevalence study or an ecological study. Any other questions?
Not for now. I just wanted to say that maybe it's worth also remembering that not in all cases you might have the possibility of doing randomized controlled trials. So looking at the cost of a prevalence study compared to a randomized controlled trial, there are some conditions you might only be able to do either a case control, a prevalence study, and not a randomized control trial or a cohort study. So it's not because you did a prevalence study that the study was not good. It's also cost effective.
Sure.
And Madhu, also,
yeah.
Oh, sorry, go ahead.
Go ahead.
Nope, you can answer.
Go ahead.
Well, I think if you're going to respond on Ia's point, please do. But I think there's also, I don't think everybody understands what confounding means. I mean, Ia's given a good definition in the chat, but I think if people don't understand that very well, that could be a challenge to understand the material. So someone asked for you to give it in kind of a way the journalist can understand it very clearly.
So confounding, I think the BCG thing is a beautiful example, right? So countries that give BCG seemingly have lower incidence of COVID, right? But that's just two variables, right? BCG and COVID. What else is happening in the background, right? What else could create this illusion of an association between BCG and COVID, right? So age structure of the population is a huge confounder, right? Because countries that generally give BCG are poorer countries, and poorer countries generally have a much younger population, right? That's a fact. And countries that stop giving BCG are the richer countries where TB has gone away, Europe, North America, and so on and so forth. And Europe and North America have large numbers of elderly people, age 60, 70, 80s. And we know COVID really has a bad effect on elderly people. So what we think is BCG and COVID might well be underlying issue could be age of a population and COVID, right? And so the apparent association between two variables, BCG and COVID, is confounded by a third variable that is associated with both the exposure and the outcome, right? So age definitely is associated with the decision to give BCG or not. And that's mediated by the richness of the country and the fact that TB has gone away. And age is also associated with COVID mortality. And that's a good example of confounding. Does that help?
Yes, I think that was very clear.
All right.
I hope it helps
So
everybody else.
let's go on to the last talk I have, and then I will be able to hand over to Taryn. Yes.
Thank you, Dr. Pai. My name is Esther.
Yes.
And I'm asking about ecological studies. And in journalism, we have what we call reporting about passive controversy. You know, this is a controversy about BCG and it's a confounding, like you have explained. But as a journalist, probably I've got a duty to give two sides of the story. So the researchers have come up and said BCG and countries that vaccinate against, that are doing it have low COVID-19 cases. And then I have you, Dr. Pai, say, this is complete, this is nonsense, this is not good, this is ABCD. So my duty in this sense would be for me to present these two opposing sides, you know, to the public. And I think, in my opinion, there would be nothing wrong with that.
I fully agree with you. What I'm worried about is these ecological correlations being presented with no critique, right? So
Okay.
if you had only showed data saying that somebody's study shows BCG protects against COVID with no critique, then I would have a problem with that. But if you presented that along with all the list of critiques that I showed you in my slides, then I would say that's a balanced report, right?
Okay, sounds
And
good.
then you should also then say that ecological studies are insufficient for policy making because they're only looking at macro level data, which may not hold at the individual level. There are these randomized trials currently ongoing on BCG and COVID, and we should wait for the results of those trials to decide whether BCG is a worthwhile vaccine to give in this COVID pandemic.
Okay, so, but have you seen cases where governments or policymakers are actually looking at these ecological studies to make policy? I mean, you've just shown us an example of India, but is it a common practice? Because I'm thinking coming up with policy is a whole system, and it is much more or less controlled by you, the scientists. So why would scientists go ahead and do policy and they're looking at these ecological studies and they know that they are actually flawed?
So meaning normally I would say nobody will be making any policies on the basis of ecological studies. But in this pandemic, people have gone mad, right? You saw what happened with hydroxychloroquine. Based on virtually no worthwhile data, countries just jumped on it, right? From United States, Brazil, India, complete madness and complete abandoning all scientific principles. Nobody should have started giving out hydroxychloroquine on the basis of one little study from France, that too non-randomized, right? People should have waited for randomized trials. And if they had waited till this week, there are 5 randomized trials showing no benefit of hydroxychloroquine. So how much time, effort, and money and opportunity cost these countries lose by promoting a rubbish therapy which doesn't work, right? So sometimes we have to really tone down this zealousness or zealous approach to running with something. Like, I'm worried that the countries will jump in and start BCG vaccinating without even a shred of experimental data linking that BCG can actually protect against COVID. There isn't even animal experiments showing that BCG can protect against COVID. So if we are going to chase down a bad path that actually prevents a real COVID vaccine from coming online, a real viral COVID vaccine designed for COVID, then that's a massive diversion of resources and talent. It's not easy to give BCG vaccine to a country. Lots of time, effort, and money goes into it. I would not want to chase that down that rabbit hole unless I'm convinced the vaccine works. So we are in this bad shape in this pandemic because our policy makers and leaders have abandoned science. They're in fact anti-science in many countries. And it's disastrous. It's playing games with the lives of populations. Countries that have listened to their leaders have done, to their scientists, have done way better than US, India, Brazil, and a whole bunch of countries. So as media journalists, I would argue you have a responsibility to tone down rubbish and say, how do you make such a big decision on the basis of an ecological correlation or a cross-sectional weak study? Why are you not waiting for higher quality evidence to come in? That's what I would do as a journalist. There's a handful of us fighting this misinformation campaign. I mean, look at that WhatsApp video by that woman promoting hydroxychloroquine that has gone viral around the world. She basically told all of us that she's treated some 300 people with hydroxychloroquine and they're all okay, and therefore we should give it. What the hell? Who is she? Why is her opinion making a difference? I want to see trials, and I've seen 5 good trials, all published, showing that hydroxychloroquine does nothing, right? Why would I trust her anecdotal experience over much better randomized double-blind controls trials published in the peer-reviewed literature? And yet lunatics like Trump are still promoting hydroxychloroquine as of today. It's disaster, right? People are dying. This is not a joke. And we as a scientific community have failed in our ability to do good science and communicate it. Journalists have miserably failed, and our leaders have spectacularly failed us, right? Spectacular failure on behalf of our leadership to protect us in this pandemic. They've all taken ridiculous shortcuts and promoted pseudoscience and junk science, and they have really failed to do what is required. Countries that have done it have done much better, right? So I will send you my piece and my webinar with the leaders of Kerala state in India and Malaysia, where they've run really well. And as of Vietnam, New Zealand, a whole bunch of countries that have done sensible things, and they've done much better in this pandemic than countries that have done rubbish. Sorry for the rant, but your question was such a good one. Okay. All right.
Madhu, can I add a little bit
Please
to your rant?
Yeah.
No, I really liked Esther's question as well, and it made me think about the huge responsibility that journalists have, not just for this pandemic, but for any epidemic or outbreak. Because when you have weak leaders, I think journalism as kind of, that third arm of government, or somehow, they have a huge influence on the population. So, for example, the study that you showed, the ecological study that was showing that countries that people smoked more, it actually looked like they were having less COVID. I mean, BBC reported that. BBC reported that. And the thing is that if that's a big story, that validates the smoker, people, they're not waiting.
Absolutely irresponsible.
Exactly. They're not waiting for the story. Go ahead, Madhu.
Even the magazine Economist ran a story suggesting that smoking may be protective. How terrible is that? I mean, I can't even understand. And journalists are one of the few people who are still asking hard questions. So in India, just so as FYI, an Indian company has developed a medicine, and based on the basis of like 30 patients, not even a phase 3 trial, the whole thing is being rushed forward by the Indian government. And journalists are saying, what the hell, 30 people, not even a phase 3, and you think the drug works? Where is the data to support any of this stuff, right? And the company says, oh, we have lots of testimonials from doctors who are very happy with the medicine. What kind of bullshit is that? I don't care if the doctor is happy or not. That is not evidence as far as I'm concerned. That's not science, right? Because doctors will cherry pick the right people to give it, and they'll be happy with their decision making. That is not science. That's not hard evidence that we look for. So I think at a minimum, journalists have to ask super hard questions, right? On the basis of what was this intervention started? Where is the data? Is it published or not? I mean, there's a whole bunch of rubbish happening with leaders who are trying to literally fool us, thinking that we will not know what they're doing, but we have to hold them accountable, I think. Okay.
Yep, I agree. Thanks.
So let's continue with the diagnostic study, because this is another area where we have tons of questions, I'm sure. So for the diagnostic piece, Ia has done a short video in French that we asked you to see if you are French speaking. I've done a short video, 10 minutes or so in English that is already on the Google Drive. Please look at it because it gives you a very nice insight on how we think about diagnostic properties such as sensitivity, specificity, and so on and so forth, okay? So let me share my slides and tell me if you can see the slides right now. Can you see the slides?
Yes, I can see that. Mhm.
Okay. So let's talk about diagnostic studies. So this is also generally an observational type of a study where we're asking the question, how good is a test for COVID, for TB, for dementia, for whatever it is that you're looking for, okay? Now, before we get into how we evaluate tests, just a quick note on how important diagnostics are, right? Could you all please mute your mics? Thank you. So the COVID pandemic is the best example which has driven home the importance of diagnostics, right? Because countries are really struggling with diagnostic testing, we're simply not able to detect COVID. And because we're not able to detect COVID, we can't manage COVID well. It's been a terrible experience for countries to realize how bad or weak their diagnostic capability has been. So we need tests. We can't manage a disease really if we don't know what is wrong with the patient, right? And testing is also important for identifying risk factors. Do you have a gene which predisposes you to breast cancer? To predict prognosis, how do you know the cancer is not coming back over time? How do you know somebody has been effectively cured? And to tailor therapy or to do personalized medicine for all of this, and even for surveillance, right? How do you know what is the baseline level of a given infection or a disease in a population? So there's an explosion of diagnostic technologies now, right? See, I have an Apple Watch on my wrist and I can get an ECG on my wrist right now. But how good is that ECG, right? How good is that ECG? Is it the same accuracy as what I would get if I went to a hospital and got all the leads stuck on my chest? Can you trust a mail-in genomic test, right? Where you take a oral swab, send it off to a lab, and they give you your genetic profile. Is an HIV mouth swab test good enough, right? Lots of interesting questions on the diagnostic related issues. Could you all please mute your microphones, please? Thank you. All right. So any of you who walked through the airport body scanner where suddenly it has gone beep, right? Know for a fact that tests are not perfect, right? The body scanner in the airport can miss somebody who walks in with a gun, or it can go off if you have a knee prosthesis or a artificial hip in your body, or even if you have a small piece of metal in your wallet or your shoe, right? So the airport body scanner has its own accuracy, right? It can be falsely positive, which means it can go off even though you're not carrying anything dangerous, or it can be falsely negative. You can miss somebody who walks in with something bad. So that is what a diagnostic accuracy study is all about, right? To decide on the parameters of a test, to know how good the body scanner is or a COVID test is, we need to know its accuracy. And accuracy is made up of two numbers, sensitivity and specificity, right? Together, they give us something called test accuracy. And so in this COVID pandemic, we know countries have used all sorts of COVID tests, and many of them have been pushed rapidly into clinical use with very little validation studies. And we know many of them are probably garbage in terms of their test characteristics. So it's going to be a huge cleanup required. Right now, countries are just taking anything and everything they can lay their hands on. In India, for example, it's like the Wild West. All sorts of companies are out there promoting all sorts of tests, and nobody has the faintest clue on the quality of any of these diagnostics on the market right now. So we need to do diagnostic trials just as we would do drug trials. Before a test is put on the market and it can be applied on real human beings, we must validate that test. It's called a validation study, right? Or a test evaluation. Just like we validate a drug before we approve and put it on the market, tests also need to be validated, right? So just because a lab is offering a test, that means nothing. The test could be complete garbage and dangerous, and many tests actually should be pulled out of the market because they're dangerous to human health. Imagine being told you have COVID when you don't have COVID. Or imagine you have COVID, but you're sent home saying you're okay, right? Wrong test results have serious consequences for people. Now, before I show you how we do validation studies in real life, I want to separate two scenarios. There is a diagnostic situation. All of you know what that is because you've all been through some diagnostic test in your life already, right? That's like you have suspected diabetes, you have suspected TB, you have suspected something, pneumonia, whatever, you had a diagnostic test. Diagnostic tests are done on sick people who are seeking care, right? Like, I'm not well, what do I have? Well, then you are in a diagnostic situation. Screening test is, you're not sick, you're not asking for help. The health system goes after you and says, please get screened for breast cancer if you are over the age of 50. Please screen for prostate cancer if you're a male beyond a certain age. Come to us and we will screen you, right? Or we will come to your home and we'll screen you. That's a public health exercise, and that is a screening situation. The biggest difference between a diagnostic situation and a screening situation is that screening situation invariably is done when the prevalence of the disease is very low, right? Most people who are screened will be negative, right? In a diagnostic situation, when somebody is sick and seeking care, the test will be done in a situation where the disease prevalence is high, right? So diagnosis, high prevalence situation, screening, low prevalence situation. And I will show you in a minute mathematically that the same test with the same sensitivity and specificity can throw up completely different numbers in a diagnostic situation and completely different numbers of false positives and false negatives in a screening situation, right? The setting or the screening situation really makes a difference, okay? Now, diagnosis really, as much as we would like to think that diagnosis gives us great certainty, in reality, if you ask any clinician like me or anyone that you know of, it's a game of probability, right? We think you may have something, we get some information, and then we revise the probability, and then we get another test, and now suddenly we are more sure about what you have, right? We accumulate bits of information, and then together the entire story then leads us to believe that you have this or that disease, right? So it's a play of probability, and we're trying to get higher and higher on the certainty scale, right? So let's see how this works. So here is a scale, probability of diagnosis. When your probability of a disease is very low, around 0%, 5%, 10%, then maybe you shouldn't even be testing for that disease. It's dangerous to run behind something when the risk of the disease is very low, or a probability of the disease is very low. Sometimes the probability of disease is quite high, right? You already know that the profile of the patient and the test results have all come in, and this looks absolutely like slam dunk. In that case, you just treat, right? You just treat. The biggest value of a diagnostic test is in the middle zone, right? That's the zone where the probability is not so low that you ruled out the disease. Probability is not so high that you ruled in the disease. You are in the middle. That's where the uncertainty is the most, where the doctor is scratching her head and saying, I don't know what on earth is wrong with you. I'm going to ask for a test. And that's great.
Excuse me, Madhu, sorry to interrupt, but your screen is not scrolling. I think it's frozen or something. I don't know.
Nothing is coming on.
Slides. Like we can see the slides, but they're not moving. Like yours, it's just on your title slide.
Oh, glad you pointed out. So I may have to stop sharing and share again, okay? Can you see
Okay,
the
yeah,
slide
now
now?
we can see the process of diagnosis.
Okay.
Yes.
So you have not seen a single slide after title slide?
No.
Okay, so let me go back then. All right, so I was just trying to explain why screening and diagnostic tests really matter, how important they are to detect disease, predict prognosis, monitor treatment over a period of time. And then I also gave you examples of an explosion on various diagnostic technologies that are now available, including home-based tests, wearable devices, so on and so forth. And it's important to know whether these tests work or not. And I was giving you the airport scanner analogy to show how even an airport scanner has its own false positives and false negatives. And therefore, we should validate all diagnostic technologies, right? And too many COVID tests have been introduced without adequate validation. So the difference between a diagnostic test and a screening test is that diagnostic test is done on sick people who are seeking care. Therefore, their pre-test probability of disease is quite high. Screening test is usually done on apparently healthy people who are not seeking care, and therefore the pre-test probability of disease is quite low. So I was explaining that we need to think of diagnosis as a probability game, right? It is a probability game. When the probability of disease is very low, we shouldn't be testing really, right? We should leave people alone and not be chasing after something. When the probability of disease is very high, we probably don't need to worry about testing. We can just treat. The real issue now is somewhere in the middle where there's a lot of uncertainty, and that's where we need to test. So in a perfect world, and I've shown you this graphic before, everybody with the disease will have a certain easy value on the test. Everybody without the disease will have one value, everybody with the disease will have another value, and these two populations will be beautifully separated. Imagine if there was a COVID test where everybody with COVID, their hair turned purple, and everybody without COVID, their hair remained a normal color, right? Then the whole world will instantaneously know who has COVID and take better care of them. This epidemic can be brought under control very quickly, right? Unfortunately, there is no such test. In reality, there will always be a big overlap between people with the disease and people without the disease. Therefore, we're always confused on whether somebody truly has a disease or not. And this is easy to understand, right? Imagine if you had a distribution of people with high blood pressure and a distribution of people with normal blood pressure. And these two populations, there will be some overlap, which is why no matter which cutoff point we use for hypertension, 140 systolic over 90 diastolic or 80 diastolic, or whatever you want to use, there will always be a risk of misclassifying some people depending on where we draw the cutoff, right? That's a cutoff that we could draw. In this case, imagine if I drew a cutoff here, there'll be a bunch of diseased, healthy people who will be called diseased, and there'll be a bunch of diseased people who will be declared as healthy, depending on where we draw the cutoff, right? So this is a challenge in all tests, which is why cutoff points matter a lot. For example, I've just given you an example from my field. When we do the tuberculin skin test or the PPD skin test, sometimes we use a cutoff of 10. Sometimes for people who are in close contact with TB patients, we use a cutoff of 5 millimeters, sometimes 10 millimeters, sometimes 15 millimeters. So there's no point in saying a test is positive without saying what cutoff was used, because it's important to understand that. Same thing for antibodies for COVID. How much antibodies do you need in your blood before you say the COVID test is positive, right? Every test will have its own inherent cutoff, and cutoff points can change over time. In the past, hypertension was 160 systolic and 100 diastolic, for example, right? Because the people didn't want to declare people to be hypertensive, and that cutoff has become lower and lower and lower. And so now we need to worry about 140 over 90, for example, as a cutoff for hypertension, right? There is something called Bayesian theory, Bayes theorem, as it's called, named after a British reverend called Thomas Bayes, and he wrote this famous essay on chances, right? He's a probability expert. So when you say Bayesian, that means you are now in a realm of probability. So what is Bayes theorem in simple English? What we thought before we did the test plus new information obtained from the test is equal to what we think now, right? The game of chances works like this. If you walk into a clinic and you, for a certain age, a certain profile, you have a certain family history, you've been in contact with someone with COVID, whatever, you already have a picture forming in your head, right? Then you say, I have fever, then you have cough, and then you had a coworker with whom you were in touch and that person had COVID. Suddenly all this information is adding more and more value. I already have a fairly good idea in my head that you have COVID-19. Then I order a COVID test, it comes back positive. So in the context of all the information I got from you, plus your history of being exposed to someone with COVID and your classic symptoms, in the context of all of that, a positive COVID-19 test pretty much confirms that you have COVID, right? So I'm taking the history, clinical information, and other information, then I'm ordering a test, and then I'm changing my decision on whether you have COVID or not. So in mathematical terms, we compute what we call pre-test probability, then we do the test, and then we use these two to compute the post-test probability. The actual formula is post-test probability, or odds, is equal to pre-test probability multiplied by likelihood ratio. And likelihood ratio is the property of a test. And likelihood ratio is directly derived from two numbers, sensitivity of a test and specificity of a test, which I will now explain in a second, right? So now I want you to understand how the Bayesian approach to diagnosis works. A good test is one where the pre-test probability might be low, say 10%, 20%, 30%. The test result comes back positive, right? Your post-test probability is now close to 90 or 100%. The test is good enough to take you to a relatively low or a middle probability zone and pretty much push you to a level of certainty, right? In this situation, you say, yes, the diagnosis is confirmed. The word we use in medicine is a diagnosis being confirmed or the disease being ruled in, right? We've ruled in that somebody has COVID, right? So this is a good test. It has enough good information coming out of it. The sensitivity specificity is high enough to push you into the realm of definite diagnosis, okay? It's a good test. This is also not a bad situation. You think somebody has cancer, okay? Then you do the test. The test is good enough that the post-test probability of cancer is now very low, right? Low enough to reassure them, you know what, great news, you don't have cancer, you can go home, right? We worried about it, we tested you, the test is clearly negative and the test is a good one, and therefore we are done, we don't have to chase this cancer diagnosis. That is also a great situation to be in. What we hate in medicine is a test is so wimpy and weak that pre-test probability multiplied by the test property still gives us the same answer. In other words, the test is not good enough to rule in or rule out the disease. That is not a good test to have. And that situation will happen when the sensitivity and the specificity of a test are very poor, right? When the sensitivity and specificity of a test are high, the test will invariably be able to rule in or rule out, as the case may be. So I'll give you examples of how we interpret this. In general, how do we go about evaluating a diagnostic test? First, we cannot evaluate a new test if there is no benchmark to compare it against, right? The benchmark we compare a new test against is called the gold standard, also called a reference standard, right? So let's imagine I have a new iPhone test, right, on my iWatch, a test which tells me that I'm having a heart attack, okay? The watch, is it a good one or not, or is it likely to produce all sorts of rubbish because the watch is not a perfect, it's not even a diagnostic, it's a watch, right? So what do I compare my Apple Watch ECG against for heart attack, right? I need to compare it with what is already established in the medical field as the best test for heart attack. And that might be an angiogram where they inject a dye and then make sure that the coronary arteries are narrowed, along with cardiac enzyme elevation and other symptoms, okay? So there may be a gold standard that's already well established in the field of cardiology. That is what I need to compare the watch performance against. So we call that a gold standard. We also call that as a reference standard. So we recruit consecutive patients in whom the disease is suspected. We do the gold standard on everybody. Then we also do the new test on everybody, okay? So you have the same people on whom you have the gold standard test information and you have the new test information, okay? So in the case of the Apple Watch, I have the Apple Watch ECG results on everybody with suspected heart attack. I also have their angiogram as the gold standard. If I had that, I can set up a 2x2 table, just like the 2x2 table you saw it earlier in the first week of the course, and I can compute numbers called sensitivity, specificity, and predictive values. And I'm going to first show you how we think about sensitivity, specificity in a visual way, okay? So imagine a hypothetical population, some with disease and some without. So all the black dots are people with the disease. All the white dots in this population are people without the disease. So let's assume that the black dots are all people with COVID-19, okay? And all the white dots are people who don't have COVID-19. So then we do the test. Let's say this is a new COVID test approved in your country. And let's say everybody in this population is positive on this new COVID-19 test. Now, this is a terrible test, right? It has picked up all the black dots and they've all been declared as COVID-19 on this new test, but it has also taken every single healthy person and wrongly labeled them as COVID-19, right? This test is highly sensitive. In fact, it's perfectly sensitive because it has picked up all disease people. But its specificity is disastrous because it has wrongly labeled a whole bunch of healthy people as COVID-19. Okay, so this is a great example of a test that's 100% sensitive, but terrible in terms of its specificity. In fact, the specificity is 0 because all of the healthy people have been wrongly labeled as having disease by this test. So not a good situation to be in. Now let's imagine this situation. The test picks up as positive all the black dots, good. The test picks up as negative, which is a green zone, all those who are healthy. Now this is a beautiful test, right? It has nicely separated the diseased people and picked them up as disease, and it has identified all the others as negative. This is a fantastic situation, right? In this situation, the sensitivity is 100%, the specificity is 100%, right? Now, in reality, you will not find this. You will not find this. You will be in this situation most of the time in medicine, right? I don't care which disease. This is how reality often plays out, right? There's very, very few tests in medicine that are close to perfect. In reality, what will happen is you will have a whole bunch of people whom the test correctly identifies as diseased, but some black dots will get missed, right? These people have the disease, they are black dots, but they have been missed by the test and declared as negative. We call these 6 people falsely negative, right? False negatives means there is disease, but the test is falsely negative. Now, in this situation, these green dots are all correct, right? They are healthy and they've been declared as negative by the test, which is good. But the test is lit up positive on a bunch of people who don't have the disease, but they have been declared as positive on the test. These people are called false positive. They are falsely positive, and that's a problem, right? So you can have false negatives, you can have false positive. Therefore, the sensitivity and specificity of this particular graphic will probably be around 90% sensitive and 90% specific. It's not perfect. So it will produce some false positives and some false negatives. So here is how we do a diagnostic 2x2 table. It looks very similar to a standard epidemiological 2x2 table that Ngozi taught you early on in the course, right? We have diseased positive, disease negative. How do we know disease positive, disease negative? Because we've done the gold standard, right? So the gold standard, all those who are gold standard positive, say angiogram positive, are here in the first column. All those who are angiogram negative are in the second column. And the new Apple Watch test positives, the Apple Watch test negatives. And these 4 cells are true positive, false negative, and true negative. And this is the video that I've actually done and uploaded already. So I won't spend too much time on this, but I will just show you how we compute sensitivity, okay? Sensitivity is among all people who truly have the disease, okay? Say, for example, all people who are angiogram positive and have a heart attack, what proportion of them will be picked up as Apple Watch positive? So cell A divided by the entire column total gives you a percentage. That percentage is called sensitivity, right? If every single person who's angiogram positive is also positive on the Apple Watch, then this proportion will be 100%. The sensitivity will be 100%. Now, what is specificity? Among all those who do not have the disease, gold standard negative, angiogram normal, what percentage is picked up as negative by the Apple Watch, right? That cell value, cell D, divided by the entire second column total gives you the specificity of a test. And together, we can estimate the true positive rate and the false positive rate of a test if we had that information. And that's how we compute something called predictive values. Predictive value of a test now approaches this from the perspective of a test rather than the gold standard. You're now asking, among all those who are Apple Watch positive for a heart attack, what percentage truly have heart attack, right? That's called predictive value of a positive test, also called a positive predictive value. Now we are flipping the directionality of our inquiry. We are asking, if the Apple Watch says heart attack, does this person truly have a heart attack? If the COVID antibody test is positive, does the person truly have COVID-19 or not, is what a predictive value positive is telling us. And the same thing we can do for a negative predictive value. If the Apple Watch is negative, what is the probability that somebody truly is healthy and doesn't have a heart attack? That gives us a second predictive value. So sensitivity, specificity, we look at it from the directionality of a gold standard, top down, vertically, and we compute those conditional probabilities. And then for predictive values, we look at them horizontally from the perspective of the new test, and we compute the probabilities. All 4 are simple percentages that we can get from the same 2x2 table, okay? So in the video that I've shown you, I have given you a nice worked out example of a gold standard against which an antibody test for COVID was done, a real study, where I've shown you the sensitivity is 85%, specificity is 94%, positive predictive value is 93, negative predictive value is 87, right? And then I've also shown you what happens if you take that same test, this test, with these properties, 85% sensitivity, 94% specificity, and then you start doing it on an entire community, right? Like Santa Clara County. You go and survey a whole population where the prevalence of COVID is reasonably modest, only about 30%. If you were to test 1,000 people in that community with a COVID prevalence of 30%, then with the 85% sensitivity and the 94% specificity for that particular test, you will generate this 2x2 table and you will end up with a predictive value of about 86%, right? In other words, 86% of people who are antibody positive will truly have COVID in this community with that baseline prevalence of 30%. Now I do it in a very low prevalence population, like Santa Clara County. Remember, they said 1.5% of people had antibodies. If you applied it in a very low prevalence community, the same test with a fairly good sensitivity of 85 and a fairly good specificity of 94 will now dramatically have a lower predictive positive value, which means only 1 in 5 people who are antibody positive will have COVID. The remaining 4 will be falsely positive. The moral of the story is, even if a test is really good and has high sensitivity and specificity, if you suddenly take it to a low prevalence population and you screen people, you will find lots of positives that are not really diseased. In other words, false positives are guaranteed in a community survey or a population-wide study because you're suddenly taking a test and applying it to a population with low prevalence. So a diagnostic setting test, which works very well in sick people in the hospital, may completely fall apart when you take it into a population setting where most people are healthy, right? Therefore, we always worry about false positives when we do a population-wide survey because we are applying a good test. It may be a good test, but it will still produce lots of false positives in a population setting. So just to say that diagnostic studies also have to be done well. There's plenty of biases that we can see in a diagnostic study. For example, one common bias is that the gold standard might be quite bad. If we compare a new test against a bad gold standard, the results can actually be uninterpretable and very confusing, right? If you also cherry pick very sick people in your study and compare them to very healthy people, then you will end up overestimating your sensitivity and specificity. So we worry about a whole bunch of biases when we do diagnostic studies. And if you look at the Google Drive, you will see we have an entire critical appraisal worksheet just for diagnostic studies, right? So the take-home messages here are diagnostic tests are never perfect. They all need to be validated carefully before clinical use. Diagnostics test is very different from a screening test. And every test has its inherent built-in error, and that error is quantified by 2 numbers, sensitivity and specificity. Sensitivity and specificity directly give you false negatives and false positives, okay? And the test that might work very well in a hospital might produce lots of errors when you apply it in a population setting, which is what is happening with COVID-19. If you go to a random community and start testing for COVID, you must account for lots of false positives that the test will produce. Questions, comments? And Taryn, while I take questions, can you check if you're able to share your slides, please?
Can I ask a question?
Yes, Esther.
Yeah, thank you, Dr. Pai. That was interesting. So in terms of COVID-19, we have the nasal swab that is being done, which is pretty uncomfortable. Mm-hmm. And we are looking at PCR as the gold standard. But we know that companies are also coming up with other diagnostics where you can spit and do ABCD. So my question is, does it matter the material that is used in terms of the diagnostic to give you the sensitivity and the specificity?
100%. The sample matters, when you collect the sample in a sick patient matters a lot in this COVID pandemic, right? If you test someone first day they had a cough or a sore throat versus sixth day, or someone you test them after 14 days, you will get very different results because the sensitivity varies a lot, right? Too early, not sensitive enough. Too late, not sensitive enough. Antibody tests have a very different sensitivity specificity than antigen tests. PCR tests have very different sensitivity specificity than antibody tests, right? Which test, which patient, which sample, and when the test is done makes all the difference in this COVID-19 pandemic. All right?
Yeah.
All right. Over to, yeah, go ahead.
Dr. Pai, good evening.
Yes.
This is Joan.
Yes.
Doctor, in relation to what Esther has asked, it's also about the materials. Now, there was the issue of, for instance, we had that issue in Tanzania where the president sent samples of pawpaws, is it goats, to a lab, to various labs, and some results came out that these materials tested positive, and that's why he was acted. So what really, what would really be the question there?
Sorry, go ahead.
Can you hear me now?
You're breaking up a bit.
Can you hear me?
Yes.
Okay, I was saying, my question is in relation to what Esther's just asked. It's about this instance where we had the president of Tanzania, President Magufuli, sending samples of oranges, pineapples, goats, you know, all that, and sent them to the various labs in Tanzania, and the results were shocking. Some of those materials tested positive. So the question was, how? I think that's where the whole thing started, of him saying the country will no longer report about COVID. But what can you say about that? Can I ask another question, or you first answer that one?
No, I think if you have more questions, please put them in the chat box and we'll answer them through our Q&A document. But just because some labs are producing false positive, whatever, we need to improve the labs and we need to improve the tests. But that doesn't mean Tanzania or whatever should stop testing for COVID or reporting for COVID. That makes no sense. You try to find that if some tests are poorly performing, then we should throw them out of the market. Or if some labs are doing a bad job, those labs should stop doing the tests. We should find high quality labs and high quality tests and continue testing for COVID. We can't give up on COVID testing or reporting of COVID data just because some false positives were produced. Does that make sense?
Yes, doctor, it does. Now, lastly, it's about the tests. There were issues about the rapid tests in the beginning. I think those test kits that were donated by China to various countries, including Uganda. And initially, the government laboratory was saying they had reservations about it. So this is about the rapid tests, their results in terms of the sensitivity and the specificity that you've been talking about. And then also now the blood tests. I know you talked about the materials, depending on what they are, they can be used for various purposes. But then just the distinction of the rapid test vis-a-vis even.
Yes. So there is a systematic review.
Which would be.
So there is a systematic review in the Annals of Internal Medicine by our team at McGill, which clearly shows that rapid tests perform poorly compared to ELISA for antibodies. And so I'll ask you to look at that, because yes, you're absolutely right. Certain rapid tests are really performing poorly and they should not be used either for diagnosis or for surveillance purposes. All right. Okay.
Hello, doctor. Can I ask a question?
Can we please let Taryn finish? Can we let Taryn finish her talk? And then I promise you I'll stay back and answer more questions. Okay? Over to you, Taryn.
Hello, can I ask?
Can we wait until the talk is over, please? And then we will answer questions. Go ahead, Taryn.
Hi, thanks. Thank you, Madhu. I am going to put my video on just in the beginning, just to say hi to everyone. And then I'm going to switch off just to make sure that the quality of the call maintains. So just a cross-check to make sure that everybody please mute their microphones. That will be great. Thank you. So the talk that I'm going to be taking you through is around systematic reviews, which is a form of research that's often referred to as secondary research. And it's all about taking stock of all of the existing knowledge and existing research that's available. From the pyramid and the picture that you can see on the right hand side of the slide, you can see you now recognize the different types of study designs that's there, and you see that we have systematic reviews right at the top of this hierarchy, which is not necessarily something that's been happening within the time of the response to the current pandemic. When we're talking about reviews, sorry, my slides moved a bit fast. So when you're talking about reviews, it's another way of referring to it is that it's a relook or a further look at what has been happening or what has been written in the past. So I want to share with you one scenario linked to pregnancy. So you know, when a woman gets pregnant and she normally delivers around about 36 weeks, that's the time when it's referred to as term. And if you can picture a scenario where your niece or your daughter or your sister has fallen pregnant and everybody is really excited about this new arrival to the family. And then when she is 26, 27 weeks pregnant, she suddenly goes into premature labor. And one of the things that one can consider is to actually give the mom some steroids so that it can help to mature the baby's lungs, so that when the baby's born, there's no problems in terms of lung problems. So with you having attended the course now on epidemiology, your family asked you to actually give some guidance around whether steroids can be used or not. So I know in some cases when you're being asked for evidence, you phone a friend. I think after having the course with Prof. Pai, you will be phoning Madhu for advice. And some of you will be turning to the literature to go and find particular answers. Now, if it was in the early 1980s, you would have found this expert review that was published by Robertson in the BMJ. And this conclusion from Robertson in terms of this review was that the evidence suggests that antenatal steroids are of value only in white males, and even then the benefit is only for those who are being delivered between 30 and 32 weeks pregnancy. So if your sister, which is going into premature labor, at 27 weeks, at that time, if they were basing practice on this particular review, she would not have been receiving the steroids. If we fast forward a little bit further, in 1989, a systematic review was published that clearly showed that there's a lot of benefits for steroids for women who've gone into early labor, that there's between 40 and 60% reduction in lung problems, between 10 and 80% reduction in brain or bleeding in the brain, on the brain, And in terms of deaths of these babies, between 25 and 50% lower risk of death for those who have received these steroids or not. And you may wonder, so why am I telling you this particular story? And for me, this is one of the key stories that illustrates the impact and the human cost of not using best available evidence. Because no well-conducted review was available up until 1989, thousands of women that went into premature labor missed out on receiving steroids, and as a consequence, the babies suffered from severe lung problems, or those babies died because they didn't receive this very worthwhile treatment. And worst of all, if we go back to the 1982 review, at that time, there was actually results from 7 randomized controlled trials available. But in that expert review, those trials were never included. On a personal note, I'm very thankful that my own son, who was delivered at 27 weeks and weighed 1.2 kilograms, was born in 2000, which means the first treatment I received when I arrived at the hospital was a steroid injection. Okay, so the little giraffe next to him is the same length as a fork that you will eat with. And I'm happy to say that he is now starting university and is doing very well.
Taryn, some people are having trouble hearing you. Can you speak up a little more, please?
Okay, I will do so. So let's talk about the review a little bit more. So I've mentioned that it's a relook or way of looking at the evidence that has been published around a particular topic. And the most important part is that it's not just a summary of what is out there, but it's also a critical reflection of the quality of the evidence. So when you're reading a review, you also need to see whether it was done properly, because if you didn't follow good processes for doing that review, you will also find a biased summary of the available evidence. So I want to take you through a few of the biases that you must be aware of. So if you're looking for existing studies that is out there on a particular topic, you must search comprehensively to identify all possible studies that's available. If we just walk through this flow diagram, if you think of all randomized control trials that's available, some of them may be ongoing and some will be completed. Of those that's completed, only some of them will actually be published. And when they are published, some will be in peer-reviewed journals and some will be in the form of abstracts or as PhD or master's dissertations that's published on the university site. And even if it's in a journal, one of the favorite databases to search would be Medline. It's only certain journals that you will pick up through Medline. So when you're doing a review and you want to find all studies, you need to make an attempt to search more than just Medline. You need to search and look at abstracts and dissertations that's been done by students. You must try to find unpublished studies, and you must also look for ongoing studies.
Please mute your mics. Please mute your mics. Thank you.
Okay, I think I'm gonna. Okay, let me proceed. So the first thing is to have a comprehensive search. Then there are further biases that one needs to try to avoid, and that is when you are selecting studies for inclusion in your review, you need to ensure that you include all possible studies and you have a very objective way of choosing which studies are included or not. And one way of minimizing a selection bias is by having two people working independently, applying pre-specified eligibility criteria around which studies will be included or not. Another potential bias that one wants to minimize when you do reviews is around paying attention to the quality of those studies. Now, in the past few sessions with Madhu, you've heard a lot about bias, selection bias, information bias, confounding. And when we're talking about trials, a whole other set of biases were also covered. So when you're doing a review, you still need to assess the quality of all of the studies that's been included within that systematic review. So far we've touched on that you need to search widely. Once you have your search results, you must be transparent in how you select studies for inclusion. And once you have it included, you need to assess the quality of those studies. And then lastly, is you also need to take note of what the size of those studies are. So how many participants did they plan to include in the various studies, and how many did they actually end up including within those studies? So which steps should one take to make reviews more reliable? And one of the key steps to start with is to be very clear on what's the question that you want to have answered. And I'm going to show you an example shortly. You need to have methods that's pre-specified. So if you're doing a systematic review, you actually need to write your protocol for that review and register it beforehand, before you start with doing it. And in that protocol, you need to pre-specify which types of studies are you looking for, what kind of participants are you interested in, what kind of intervention. If it is, for instance, a systematic review on hydroxychloroquine, you would want to specify that that's the intervention that you're looking at. Then you need to clarify how you're going to search for studies and where. You need to have an approach for assessing the validity of the included studies, and also how you are then going to combine all those findings. And ultimately, you need to have a very clear and complete presentation of the findings, because what you're working towards is the current state of knowledge around that particular question, with the strengths and the limitations of the research. So some of you were asking a bit earlier around in terms of turning to research evidence and wanting to inform the messages that you put out in the media. If you, for your question, if you can find a well-conducted systematic review that is up to date, that will be the best prize for you to then use to inform the messages that you want to put out in your story. So what is a systematic review? This is one of the formal definitions. It's a review where bias has been reduced, and some of the key words that it's been reduced through systematic identification, then appraisal, and then synthesis. And where relevant, even doing what's called the statistical aggregation, and that is where meta-analysis fits in. So when you combine results statistically, that's a meta-analysis of all relevant studies on a specific topic and according to a predetermined and explicit method. So there's quite a lot captured in this definition, but it gives you a very good definition of what a systematic review is all about. So I mentioned briefly what a meta-analysis is. So meta-analysis is the analysis within the systematic reviews. And in some cases, you will find a systematic review without the meta-analysis. And that is fine, because you only conduct a meta-analysis where it is appropriate. So we're not going to go into the detail of doing meta-analysis and various statistical tests, But this is the classic, what's called a forest plot, which is the representation of the results from a meta-analysis. So these are two forest plots that comes from a systematic review that's been done to look at risk factors for the severity of COVID infections. And the top one gives you the results for diabetes. And the one at the bottom is the results for hypertension. In a summary, when you look at a meta-analysis, the vertical solid line that you see, this line here, the vertical solid line that goes through the point where it's a 1, because in this case, they're using what's called the risk ratio to see if there's a difference. They take the risk of how severe is the condition in those with diabetes compared to without diabetes. And they divide those two risks with each other. If you get an answer of 1, it means there's no difference. So the vertical solid line is the line of no difference. And then the individual lines with the little blocks represents the results for each of the studies that were included. So you can see in the top one, there were about 10 studies included that looked at diabetes, and about a similar number of studies that looked at hypertension. So that's just a brief overview that of what you get for the individual studies. And then you see for each of these, there's a little diamond lower down where it shows overall effect. And that diamond is where all these results have actually been combined. So they conducted a meta-analysis. They combined the results from all 10 studies, and they came up with an overall finding to show in both of these cases that if you have diabetes or if you have hypertension, you are more likely to have severe COVID infection compared to those who do not have diabetes or those who do not have hypertension. So this is one of the really neat things about the systematic review, is that you can take independent studies, and if they are similar enough, you can combine the findings to get the totality of the evidence. So let me take you through another example, and I'm showing you examples that's been published in the Cochrane Library, the Cochrane Database of Systematic Reviews is one of the databases where you can find reviews that's been completed by the Cochrane collaboration. It's a very good starting point if you're looking for evidence. And this particular review has been done to look at personal protective equipment to prevent infectious diseases that's due to exposure to contaminated body fluids in healthcare staff. So the population is around healthcare workers, and to see if they wear personal protective equipment and the different types of PPEs, and whether they have a lower risk of actually becoming infected when they're wearing one type of PPE versus another. This particular review was actually for the first time done in 2016. It was then updated in 2019, and it was updated now again in 2020. So how did they do the review? Where did they search? They searched in Central, in Medline, in Embase, and in Sinal. So those are 4 databases where they searched. If you remember my earlier slide with the different color blocks in terms of if you should only search Medline, you can see here they try to search in various different databases. They also pre-specified what was their selection criteria, and I'm not going to read through all of this, but I wanted to show you that they specified their selection criteria. And they also state that once they've done their search, 2 authors independently selected studies, they extracted data, and they assessed the risk of bias of all the included studies. So you may be wondering, so after they've done all of this, how many studies did they actually include in this Cochrane review? And after they've done this third update, they now have included 24 studies in this review. 14 of those being randomized controlled trials, and then the others are non-randomized controlled trials. And these trials have been done on various PPE measures, and they have been done in various countries, in the USA, China, Canada, Australia, just to name a few. One of the things are that it's immediately striking that most of the studies have been done in high-income countries. This is the typical flow diagram that you will find in a systematic review. In this case, this is the flow diagram showing what they found in the 2020 update. In some cases, this flow diagram is also referred to as the PRISMA flow diagram. And PRISMA is a statement that's trying to guide the key reporting details that one needs to follow if you write up a review. But in essence, in this flow diagram from the top, one would describe how many records did you find, how many records did you remove after checking for duplication, and you often find duplication when you search multiple databases. Then when you screen studies against your selection criteria, you will remove quite a lot. And then you ultimately end up with a certain number of studies that's being included. Now you recall that one of the key steps within a systematic review is also to assess the quality of the studies. And what is really neat, you get these graphs, in this case, it's called the risk of bias graph, that gives you the summary of the author's assessment of the risk of bias in the included studies. So when you covered trials as part of this series of sessions, you heard about random sequence generation, allocation concealment, you heard about blinding, you heard about selective reporting. The neat thing about a systematic review is that the review authors would have assessed the risk of bias for those various elements, and they often reported as low risk, which is where you see in the green circles, or unclear risk, where it's yellow, or high risk, where it's red. And you may wonder, why is there unclear risk? And that's often linked to reporting. So where the authors of the papers didn't clearly explain exactly how did they do blinding, or exactly how did they generate the random sequence for their randomization process. And this is the forest plot that comes from this specific review example. If you look at this review, there are many analyses that they've completed. This particular forest plot is where they compared gown with the gown with gown glove improvement versus using standard gown gloves. So you can see there's two subgroups, one study in the improved versus standard group, and another study within the improved plus education versus a standard plus education group. And then we get the individual studies, and then we have the overall diamond, which shows the results where these two studies have been combined into one. The other neat thing that you will find within systematic reviews is that they also include what is called summary of findings tables. So they try to bring everything together in the summary of findings table to show, for this particular comparison, what was the result and how certain are we of the evidence. And that is when we talk about a certain tool that one can use, which is called grade. So grade is a way of measuring the confidence or the certainty of the quality of the evidence. On the right-hand side, you can see one can get, it can range from very low to high in terms of the certainty. And if you want to consider the aspects that one takes into account for the certainty, there's basically 5 factors that gets considered. One is the risk of bias, which you are now very well aware of. So it's around the question whether the studies were well conducted or not. Then you have a question linked to inconsistency. So if you compare the results of the different trials in the study, are they giving you similar results or are the results very varied? And if the results are very different, you will downgrade the evidence. You will also look at indirectness to see if you need to make a certain decision, for instance, linked to something specific in a low or middle income country setting, but the trials in the review are all in a high income setting, you may decrease for indirectness. Similarly, it may also be linked to the outcome or how the outcome was assessed. You look at imprecision, which looks at the results, and so are the results statistically and clinically important, and then there may also be other issues that you want to consider. And all of these reasons that I'm putting here are the reasons for downgrading the evidence. If you get a very strong result, in those cases you may upgrade the evidence. So when you are reading systematic reviews, have a look at the summary of findings table. It's a good starting point once you've orientated yourself to what the review is all about. And if they've done the grade assessment, it will actually give you the results about whether this intervention works or not. So if you, for instance, want to find a systematic review on hydroxychloroquine, if you look at the summary of findings table, you can see also what is the impact or the effect of that intervention and how certain are we of the evidence. So some reviews have already been completed on hydroxychloroquine, and before the randomized control trials came out, the level of certainty of evidence has been assessed as being very low. With the trials now, those reviews will be updated, and I'm sure the certainty of the evidence will be higher. So reviews can also answer very different types of questions. My focus on some of the examples that I've shown you has been on around whether a certain treatment works or not. But you can also do reviews on diagnostic test accuracy. You can do reviews on qualitative questions like what are the barriers and facilitators to healthcare workers actually adhering to the infection prevention and control guidelines. There's questions in the Cochrane review, the library, there's reviews on quarantine and how well that works. So you get reviews on public health measures. This is another example of the intervention review, which is on convalescent plasma and using that in people who have COVID. And this, for instance, is an example of a living systematic review, which means as the studies come out, it's actually in real time, the authors try to update the systematic review as new trials get added. So when should one be using reviews? My answer would be, it's always the first thing that you should be looking for. If you find a review that is up to date and it's been well done, it can either show you that something works very well, which will inform decision making for action, or it may be that it shows that we actually don't know whether this works or that it doesn't work, in which case it also informs practice. but it can also inform new research to be conducted. One must also always be mindful that when you have results of systematic reviews, to be able to make policy decisions, you still need evidence, local evidence around acceptability, around feasibility, around benefits and harms, and all of that needs to feed into the policy making process to be able to make well-informed policy decisions. So adding systematic reviews is a necessary component, but it's not always the only factor that feeds into policy decision making. Because I'm sure you're wandering around where you can actually find these systematic reviews. I've just provided in this slide the links to 5 very good resources for finding systematic reviews, especially as it relates to COVID evidence. The second one from the top, Evidence Aid, will actually provide you with summaries of systematic reviews, which is also really useful to have a look at. So it means you don't have to go and read the whole systematic review, but you can actually turn to a structured summary of an existing systematic review. So in summary, one finds quite a lot of reviews out there, and that's all that you see in the blue circle. And some of those reviews will be the traditional reviews or narrative reviews that is not necessarily being done using good methods for searching and including studies. Some of those reviews will be done, and those will be systematic reviews, and that's the yellow circle. And then where possible, those reviews will include a meta-analysis. And we don't have time to talk about individual patient data meta-analysis, but that's another type of meta-analysis that one can have. And be very careful of finding a review that's not systematic that also included a meta-analysis. So in summary, just will leave you with this quote from Sir Ian Chalmers, who's one of the founder of the Cochrane collaboration, and he says that we will serve the public more responsibly and ethically when research designed to reduce the play of chance, and that we will become an expected element of professional making practice and not an optional add-on. So thank you. Systematic reviews in itself is a whole semester long topic. So this was really a half an hour whiz through it. And if you have any questions or need any guidance around where to find it, I'll be very happy to guide you. Thank you.
Thank you so much, Taryn. You can stop your sharing of your screen. So Taryn, what we'll do is, since we are out of time almost, and Mia and the organizers want a little bit of time, I suggest we send you any questions we've received through the chat, and then you can help answer them, and we will post it on the Google Drive. Is that okay?
That will be perfect.
Okay, thank you. So we are done, folks. I know there was a ton of stuff thrown at you, but I still hope this was of some value to your journalism career and your reporting. I want to personally thank the organizers, the amazing Becky Cisa team, just worked very hard, and the Mesha team. And then, of course, Ngozi, Chido, and Ia for some amazing work and teamwork and support. I'll now ask Mia to say a few words, and then we close out. And the 2 surveys you will receive through email. One is a course evaluation that Rosaline will send, and one we will send would be your post-course quiz. Just try and do this in the next few days so that you kind of get a better sense of where you are and what you've learned during the last 3 weeks. Over to you, Mia.
Thank you, Madhu. I'll be quick. As Madhu's mentioned, there will be a survey going out, and the trick to get your certificate, if you're interested in it, is to fill out the survey. As soon as you've done that, then we'll send you your certificate just to encourage you to fill it out. It would be really helpful for us to have feedback, especially if we're planning future courses, to know what worked well and what didn't. And the other thing is we will be uploading all the lectures and all the slides onto Bekasisa's website. It will be up by tomorrow, round about lunchtime, and we'll email all of you the links so that you can access it whenever you would like to, and so that people who didn't attend the course could also do that. And lastly, I want to say thank you to all the instructors. Madhu, this course was really your idea. Madhu did a first course in India, and I heard a little bit about it and wanted to join and couldn't because I wasn't from India. And then he came up with the whole idea, no, let's do an African one. And he's the one who pulled all these partners together and who designed the entire course. And Madhu, I cannot thank you enough for caring enough about journalism to spend your time, your free time with us, and at no cost, and your ability to explain things so clearly. And also all the other instructors, Ngozi, Taryn, Iya, and Chido, we are all very, very grateful. I'm going to try and share my screen here because we made you a card. Everyone said things and said thank you. And it is a little bit big to share here. Let me just click on the right thing. Here we go. But we're going to mail it to all the instructors. Here you all can see our instructors, and some of the stuff that came out, I'm going to scroll it slowly, is that some people see this as a true gift. For journalism, many people see it as something that will really change their ability to evaluate studies and to be critical, to know which ones to quote. Some people described it as an eye-opener about things that they've never known about. The Bayesian theory certainly went down very well tonight. I saw many comments of journalists saying that they've studied this, or people with a public health background who have heard about it, but they've never heard it explained so clearly and precisely and in such an understandable way. And at Bekasisa, your Madhu studies, your bullshit studies and your garbage studies and your rubbish studies really went wild on our internal WhatsApp group. Everyone really loved those ones. And it is really lovely to get such concrete examples of sort of what to use, of what is good and what isn't. So I know it's not really possible to read all these things that I'm scrolling through, but I just wanted to show you that many people gave comments, and we will be mailing this to you, and that we are very, very grateful for all your time and all your insight, and for just caring enough about what we write and doing something so constructive about it.
Amazing. That is so touching. Ngozi, do you want to say anything?
Let me just stop the share. There we go.
Well, I just want to echo Madhu and thanking everyone. Mia, thank you so much for your team. I mean, everything you all have done has been amazing. Same with Misha. And I also want to thank you, Madhu, for including me and Chido and Iya. I really appreciate it. But I also just appreciate the contribution from the different journalists. I mean, the questions are exceptional, super curious, and it gives me a lot of hope about the journalism that will continue to go on the continent. So thank you all for joining.
That was amazing. Thanks, everyone. And I know that we've had similar requests for a course in Latin America, but I'm hoping that Spanish-speaking epidemiologists on the Latin American continent will do that teaching. So I'm trying hard to nudge them to do so. And I know we could not accept lots of journalists from Africa who applied. So I'm hoping that there can be more initiatives within Africa. And I know Taryn and Mia are already in touch with each other about that. So the more we do these sorts of things, I think the better reporting will become. And I really wish all of you the very best. So please look out for our follow-up emails. And of course, you have epidemiologists on the continent who are very good. So please stay in touch with them, build relationship with your local academics or your public health people, and have them help you critique or look through some of the stuff that you're writing about. I think it just adds a whole nother level of reporting when you bring some strong methodological perspective, because right now there's too much emotion running riot in this pandemic, not enough cold, hard thinking and science. And I think we need to find a way to counterbalance the misinformation pandemic that we are dealing with in addition to the real pandemic. So with that, I wish you all very well, a good night, and we will be in touch through email, and all this recording and the last few evaluation and survey will be mailed out to you today. Okay, bye everyone. Take care, bye.